Definition and overview of ulcers. Peptic ulcer disease, PUD, refers to the presence of open sores or lesions in the mucosal lining of the stomach or duodenum. These ulcers occur due to an imbalance between aggressive factors, such as gastric acid and pepsin, and protective mechanisms, such as mucus and bicarbonate secretion. Peptic ulcers are a significant global health issue, affecting millions of people and causing symptoms like epigastric pain, bloating, nausea, and, in severe cases, gastrointestinal bleeding. Peptic ulcers can be classified into gastric ulcers, which occur in the stomach, and duodenal ulcers, which develop in the first part of the small intestine. The primary causes of PUD include infection with Helicobacter pylori and prolonged use of nonsteroidal anti-inflammatory drugs, NSAIDs. Other contributing factors include stress, smoking, excessive alcohol consumption, and certain medical conditions. Role of gastric acid and pepsin. Gastric acid, HCl, is secreted by parietal cells of the stomach and plays a crucial role in digestion. However, excessive acid production can damage the gastric and duodenal mucosa, leading to ulceration. Pepsin, a proteolytic enzyme secreted in its inactive form, pepsinogen, becomes active in the presence of acid and contributes to mucosal injury by breaking down proteins in the stomach lining. Mucosal defense mechanisms. The gastric mucosa employs several defense mechanisms to protect itself from acid and digestive enzymes. These include mucus and bicarbonate secretion. Mucus acts as a physical barrier, while bicarbonate neutralizes acid to maintain a stable pH near the epithelial cells. Prostaglandins. These compounds enhance mucus and bicarbonate production and promote adequate blood flow to maintain mucosal integrity. Epithelial regeneration. The gastric epithelium has a high turnover rate, allowing rapid repair of damaged cells. Mucosal blood flow. Adequate circulation provides oxygen and nutrients necessary for mucosal repair and protection. Helicobacter pylori and NSAID-induced ulcers. Two major causes of PUD are H. pylori infection and NSAID use. H. pylori-induced ulcers. This bacterium colonizes the stomach lining and produces urease, which neutralizes stomach acid, allowing the bacteria to survive. It also triggers inflammation, weakens mucosal defenses, and promotes acid-induced injury, leading to ulcers. NSAID-induced ulcers, NSAIDs, such as aspirin and ibuprofen, inhibit cyclooxygenase, COX, enzymes, reducing prostaglandin synthesis. This leads to decreased mucus and bicarbonate production, increased acid secretion, and impaired mucosal blood flow, making the stomach lining more susceptible to damage. Classification of ulcers, gastric versus duodenal. Peptic ulcers are categorized based on their location. Gastric ulcers. These are found in the stomach and are often associated with H. pylori infection or NSAID use. They tend to cause pain shortly after eating. Duodenal ulcers. These occur in the first part of the small intestine and are more common than gastric ulcers. They typically cause pain that improves with food intake, but worsens a few hours later. Importance of pharmacological management. Effective treatment of PUD focuses on reducing acid production, enhancing mucosal protection, and eliminating H. pylori when present. Pharmacological management includes proton pump inhibitors, PPIs. These drugs, e.g., omeprazole, block acid secretion by inhibiting the H/K ATPase pump in parietal cells. H2 receptor antagonists. These agents, e.g., ranitidine, reduce acid secretion by blocking histamine receptors. Antibiotics, used in combination therapy to eradicate H. pylori. Cytoprotective agents, drugs like sucralfate and misoprostol enhance mucosal protection. Lifestyle modifications, avoiding NSAIDs, alcohol, and smoking can help prevent ulcer recurrence. Anatomy of the stomach and gastric mucosa. The stomach is a hollow organ responsible for food digestion and acid secretion. Its inner lining, the gastric mucosa, contains specialized cells that contribute to the secretion of hydrochloric acid, digestive enzymes, and mucus. The major cell types include parietal cells, responsible for acid secretion. Sheath cells secrete pepsinogen, which is converted to pepsin in acidic conditions. Mucus cells produce mucus to protect the gastric lining. G cells release gastrin, a hormone that stimulates acid production. Role of parietal cells and H/K ATPase pump. Parietal cells, located in the gastric glands, play a crucial role in acid secretion. They contain an enzyme called the H/K ATPase pump, proton pump, which exchanges hydrogen ions, H, for potassium ions, K, leading to acid secretion into the stomach lumen. This process is highly regulated to maintain proper digestive function without damaging the stomach lining. Regulation of acid secretion. Gastric acid secretion is tightly controlled by neural, hormonal, and paracrine mechanisms. Neural control, vagus nerve, acetylcholine. The vagus nerve, cranial nerve X, stimulates acid secretion through the release of acetylcholine, ACH. ACH binds to muscarinic receptors on parietal cells, triggering H/K ATPase activation and acid release. Hormonal control, gastrin. Gastrin, secreted by G cells in the antrum of the stomach, plays a key role in acid regulation. When food enters the stomach, gastrin is released into the bloodstream, stimulating parietal cells to produce more acid. Paracrine control, histamine, prostaglandins. Histamine, released by enterochromaffin-like ECL cells, histamine binds to H2 receptors on parietal cells, amplifying acid secretion. Prostaglandins, these compounds, particularly prostaglandin E2, PGE2, inhibit acid secretion while enhancing mucus and bicarbonate production to protect the stomach lining. Protective factors of the gastric mucosa. Despite the presence of strong acid, the stomach is protected by several mechanisms. Mucus secretion forms a physical barrier against acid and enzymes. Bicarbonate secretion neutralizes acid near the epithelial cells. Prostaglandins help maintain mucosal integrity and inhibit excessive acid secretion. Rapid cell renewal. The gastric epithelium regenerates quickly, repairing any minor damage. Classification of anti-ulcerdrugs. Drugs that reduce gastric acid secretion. Proton pump inhibitors, PPIs irreversibly inhibit H/K ATPase in parietal cells, reducing acid secretion, e.g. omeprazole, pantoprazole. H2 receptor antagonists, H2 arrays block histamine H2 receptors on parietal cells, decreasing acid output, e.g. ranitidine, famotidine. Anticholinergics, inhibit muscarinic receptors, reducing acetylcholine-mediated acid secretion, e.g. pyrenzapine, atropine. Drugs that neutralize gastric acid. Antacids, directly neutralize stomach acid, providing rapid symptom relief, e.g. aluminum hydroxide, magnesium hydroxide, calcium carbonate. Drugs that enhance mucosal protection. Prostaglandin analogs, increase mucus and bicarbonate secretion while reducing acid output, e.g. misoprostol. Sucralfate forms a protective barrier over ulcers, promoting healing. Bismuth compounds, coat ulcers, stimulate mucus production and have antimicrobial properties, e.g. bismuth subsalicylate. Drugs that eradicate H. pylori. Antibiotics, triple and quadruple therapy combination regimens targeting H. pylori, e.g. clarithromycin, amoxicillin, metronidazole, tetracycline, with PPIs and bismuth.